Today we're going to talk about the neurological side effects of commonly prescribed drugs. The drugs we're going to talk about today are prednisone, lisinopril, statins, oral fluoroquinolone antibiotics, and antipsychotic drugs. Before we actually talk about the drugs, we wanted to talk about the reasons why we think this is important. As optometrists, we're more than likely not going to be prescribing high blood pressure medication, antipsychotic medication, or really getting into the oral fluoroquinolone antibiotics. But what is important is that studies have shown that healthcare utilization in the ages of 45 to 64-year-olds are the most rapidly increasing age class. In a study that actually looked at specifically eye care utilization, they found that 40% of the 45 to 64-year-old population are accessing eye care. That amounts to about 81 million people. So those are 81 million patients that could be coming into our offices that are suffering from diseases like high blood pressure, infection, psychosis, or inflammatory disorders. So it's really important for us to know the neurological side effects of some of these drugs. The first drug that we're going to talk about today is prednisone. Prednisone is a steroid and it's usually used to treat inflammatory disorders. Some of the disorders that it can treat are arthritis, Crohn's disease, ulcerative colitis, lupus, maybe severe psoriasis, and most of the time it's used safely, but one of the best ways to have an adverse reaction to it is to not taper the drug properly. But with long-term use, you can have side effects such as moon face, buffalo hump, glaucoma, and cataracts. The neurological side effects of this, though, are increased intracranial pressure, which would result in papilledema, which can be noted in an ophthalmic dilated fundus exam. Other symptoms that you can have are ischemic neuropathy, paraparesis, paraplegia, and sensory disturbances. The next drug on our list is lisinopril. Lisinopril is commonly used to treat high blood pressure. It does this by inhibiting ACE. Almost every patient over the age of 40 is going to come in and is on some sort of high blood pressure medication, and lisinopril is a very common one. Some of the more common side effects that you can experience are lightheadedness, increased potassium, arrhythmias, lower limb swelling, nausea, and fever. But a small percentage of the patients will suffer from neurological side effects like dizziness, headaches, syncope, and some patients will experience paresthesias, which is tingling in the hands and feet. Another really common class of drugs that we're going to talk about are statins. Statins are used to treat a very common condition known as high cholesterol. What they do is they decrease an enzyme called HMG-CoA reductase. This prevents the biosynthesis of cholesterol. Why this is important is that long-term use of statins has been proven to cause peripheral neuropathy. And in a small study done by T-Fan et al., where they studied 4 patients that had adverse reactions to the statins, they showed that the clinical evidence of proximal and distal weakness and muscle fasciculations and persistent abnormalities of sensory conduction after recovery suggests the possibility of toxic damage to the anterior horn cells and dorsal root ganglion. This shows that statins used long-term can have adverse effects to your central nervous system.
The next drug class that we're going to talk about are fluoroquinolones, specifically oral fluoroquinolones. These drugs act on the DNA gyrase and topoisomerase of bacterial cells, which treats bacterial infection. Common side effects are nausea, upset stomach, and diarrhea, but there can be some neuralgia associated with fluoroquinolones. And in most cases, this neuralgia is shown to be short-term while you're actually taking the medication. But according to a study by Jay Cohen, who studied 45 cases, 36 of the 45 cases had long-term neuralgia effects that lasted a year after discontinuing the drug. The next set of drugs we're going to talk about are psychiatric medications, and there are several forms that we're going to refer to today, and they include SSRIs, SNRIs, MAOIs, TCAs, and serotonin agonists. These drugs increase the availability of neurotransmitter such as serotonin, norepinephrine, and dopamine at the synaptic cleft, which in turn enhances mood. These drugs can lead to several syndromes, including neuroleptic malignant syndrome, serotonin toxicity, and extrapyramidal syndromes. The first syndromes associated with psychiatric medications we're going to talk about is extrapyramidal syndromes, and that can be broken down further into 5 categories. The first category is Parkinsonism, and the signs of Parkinsonism is bradykinesia, tremor, and rigidity. Bradykinesia refers to impaired voluntary motor activity and manifests as a slowing of voluntary movement and interruption of normal flow of movement, which this syndrome is named after Parkinson's disease because it's the same symptoms that people with Parkinson's disease experience. The next category is akathisia. This is more of a subjective feeling of the patient where they feel distressed or uneasy and will display repetitive movements like rocking or pacing. It's harder to diagnose because it's more of a subjective feeling that the patient has. The next category is acute dystonia, which is characterized by uncontrolled contraction of muscles leading to body distortion. The most common area that it occurs is in the neck, which would lead to strange posture. The next category is tardive dyskinesia, which means involuntary movements that usually start with the tongue, lips, or mouth. It occurs after months of treatment, and these effects could be irreversible. Tardive dystonia is very similar to acute dystonia, but is characterized by prolonged and uncontrolled muscle contraction that can often have irreversible effects. Now we're going to talk about neuroleptic malignant syndrome and serotonin toxicity syndrome. Serotonin toxicity syndrome is characterized by high body temperature, agitation, increased reflexes, tremor, sweating, and dilated pupils, which you could observe in an eye exam. Serotonin toxicity syndrome can either be mild or more severe, which in its severe presentation is very similar to neuroleptic malignant syndrome, which is more rare and but it's serious, leads to hospitalization and sometimes death. This happens in less than 1% of people taking neuroleptics, and it's more common in folks taking TCAs. The effects of NMS are hypothesized to be a result of the decreased available dopamine within the hypothalamus, which results in muscle rigidity, change in consciousness, and pyrexia, which means an increase in body temperature, as well as autonomic disturbance. So in conclusion, we'd like to say that it's very important to know your pharmacology of drugs, even though you may not be prescribing them. If they're taking a drug, it's important to know what the mechanism of action is and how it could have adverse effects on their systemic and neurologic health.
It's also really important to understand the signs and symptoms of neurologic complaints and differentials for the cause. It's important to know that you need to take a very thorough history, including the medications that patients are taking that you didn't prescribe. It's also important to take note of patients' gait, how they present to the exam, what sort of mood they're in. If anything's bothering them, maybe that doesn't have to do specifically with their eyes, but that might lead you down a path of diagnosing a problem with some of the other medications that they've been prescribed.
It's also important to work with the patient's primary care provider to address any adverse effects of any of the drugs, especially neurologic adverse effects.
So thanks for listening today. Just remember, know your drugs, take a good history, and be ready to help your entire patient, even stuff that's not involved with their eyes.